Hi everyone. So in our last class, we have started the topic of electronic health records. We have started with the definition of electronic health record, and then we see that how the electronic healthcare record help to improve the patient safety, quality, and value. Then we discuss about the advantages of having electronic healthcare record, just like the paper records, need for improved patient safety and productivity. We discussed that at federal level there are support available for the hospitals and the healthcare setups. Those who would like to deploy the electronic healthcare system in their organizations. And then we discuss about the integration is the key, and some components of electronic healthcare record. I mentioned there are over 75 vendors available at this time, those who are selling electronic healthcare systems with the different specifications. Then I mentioned about the special components of electronic healthcare system, and we have started a CPOE, and I explained that CPOE is different than the ERX, which is electronic prescription. So today I'll start with the second important component, which is clinical decision support system. So let's see what is clinical decision support system and how it helps in improve the patient safety and quality. All right. So clinical decision support system, any softwares that assist decisions is a clinical decision support system. So in the EHR system, we have several components. It's like ERX, clinical decision support system, CPOE, and several others. So the characteristic of clinical decision support system, any softwares that helps doctors, paramedics in clinical decision support, we call that a clinical decision support system. So with the clinical decision, as its name suggests, we are not replacing doctors, paramedics, we are just assisting them in their daily work. Knowledge support and flow charting and graphs are the two important components. Knowledge support means the software should have some information, and the programs embedded into EHR that educate clinicians and practitioners. So in the EHR, so this is, if this is an EHR system, so clinical decision support system should be embedded within the EHR and also linked with the other components of the EHR. And it should have access to the patient data from the record, where it could access the patient data and can plot them or show them graphically, so that it could help to the clinicians to take some decisions. Now the question comes, other than the electronic, if we have some, say if we have the x-rays like in the hard format, like in the printed one, and we have the other materials that could help in taking the decision, can we say that that is the part of the system? Again, like if we have x-rays, if we have the related material, can we consider that part of the clinical decision support system? Yes and no. If that is if that is completely in a non-electronic format, we can call them a supporting material, and we are not really referring them in a clinical decision support system. But if it is an electronic and it is embedded within the EHR, we consider that a part of the clinical decision support system. Now, there are several components of the clinical decision support system. First is the order set. Then we have the reminders, we have the differential diagnosis, labs and images, and public health alerts. So let's see what is order set. In order set, inpatient clinical practice guideline for specific scenario, standardized care are displayed or listed. Now, for example, a new doctor, for example, a patient visit to a doctor, which is a new doctor and not have experience or not exposed to the disease which the patient has. So, for example, the patient come with the disease just like Ebola, or you can take any disease like a special disease in like measles, and if the doctor not have any background about that disease, so the order set can help doctors to pull out the information about the particular disease and also the steps to involve to diagnose that disease, like from where the doctor should start, what question the doctor should ask, and based on that question, what could be the possible diagnosis. So this kind of information order set is embedded in this part component. Reminders, this is pretty common. You see, you and I both receive the reminders from the doctor office, and so it's reminders about the test, reminders about the medication. So it is also part of the clinical decision support system. Then we have the differential diagnosis. That are, you can say, a software exists that help clinician analyze symptoms, sign, and to arrive at a diagnosis. These are, you can consider a sub-software. Sub-softwares are modules embedded within a clinical decision support system. And what it helps doctors to narrow down through the diagnosis and narrow down from the symptoms to reach to a diagnosis. For example, doctor asks to patient, okay, so what symptom do you have? Like, do you have the cough? Do you have this sore throat? Do you have the chest pain? And as the doctor enters these symptoms into the system at the end predicts that possibly the patient has this disease. Now, the important thing to note that this clinical decision support system does not force to the doctor or the paramedics to follow whatever the prediction is. Rather, it helps the clinical decision support system to narrow down, and it led to the doctors to take decisions to pick that. For example, if it's just that based on the cough, sore throat, chest pain, so a person has maybe a pneumonia. So the system suggests that it may have a pneumonia. It's again, it's doctor observation. Doctor can keep the CDSS prediction, or maybe the doctor say no, like it seems like just a common cold and maybe some other issue involved. Lab and imaging decision support system, at the same times when a doctor is entering the medications or entering some prescription information, a clinical decision support system can, based on the patient data entered, can advise to the doctor you can also go for these particular tests, and at the same time display the labs information as well nearby, and public health alerts. So primarily infectious disease alerts for the new outbreaks. So as this electronic healthcare system is also linked with other hospitals' electronic healthcare system. So it really helps doctors to point out any new outbreak, just like the measles, hay fever, or what is like the common based on the information which the other doctors they have entered. So the clinical decision support system really help doctors to give such kind of information. Now, that was part of the clinical decision support system. We may have in the upcoming lectures, we may have a separate section about the clinical decision support system. Clinical decision support system is really, really important in overall healthcare informatics domain. Now come to the ERX or electronic prescription. So ERX is not the CPOE, which we have discussed earlier. CPOE, sorry. So basically, this is computerized order entry system, and this is ERX. This ERX could be the part of this, right? So this is much broader, bigger. Here, the doctor can ask for the order for the imaging, order for the other lab test, but the ERX are specifically about the prescription. This is a module which helps doctors to electronically prescribe, and that is linked with the pharmacy as well. If you look there, at this time, the vast measuring of ERX occurs at the part of EHR. When the EHR started, these ERX modules were a standalone component. Standalone component was a separate software, but now majority of the ERX are embedded within the EHR system. And numbers suggest like 69% of the office-based prescriptions are now electronic. At the same time, 93% of the community pharmacies are linked with the Shore Script Network. So you can search about the Shore Script Network. This is a third-party network that facilitate between doctor office and pharmacy. So here is the pharmacy, and here is the doc office. So Shore Script works between the doctor office and the pharmacy, basically to transferring the prescriptions to the pharmacy, and then also helping in dealing with the insurance. Component of ERX and benefits of ERX. One benefit, obvious benefit, those who are working in a pharmacy or working in a hospital, I mean, you don't need to write on a pad, and because of the doctor's handwriting, and could be because of several reasons, the medical error occurs every year, and you see that over 70,000 people in the US die every year because of the medical error. So it provides when you have the online system where you have to enter that, where you have to just choose from the drop-down menu, it significantly reduces the human errors, as you have to you have a less typing. So legible and complete prescription. At the same time, the abbreviations, unclear decimal points, milligrams, micromole, all the informations are over there, where in very user-friendly environment, the doctors can prescribe a medicine with less errors. At the same time, ERX, you don't have to wait to pick up the script. You can just go to your pharmacy and pick the medicine. Fewer duplicated prescriptions. In that way, as through electronic system, things are being tracked. So with that, you can easily track if there is any duplication. Then it's a better compliance with the few drugs not filled or picked up. With the tracking system, it's really helpful for pharmacy and also for the patient to keep track whether it's a field, it's picked up, it's not. At this time, the issue with the opioid and other issues where the peoples are even taking the prescription medicine, like overuse of prescription medicine, this can be controlled with the help of ERX. Then potential to reduce workload for the pharmacist because it automates the system. Timely notifications, drug alerts. You get the drug alert when you have to pick the new medication. You can make it auto to pick the medication every month. People, they get some certain medicine for the diabetes. They get they have to keep their medicine regularly, and because of that you can set auto alerts to, and the pharmacy can send you the medication automatically as well. Ability to check formulary status and copays. This is very easier now to automatically manage that. Can interface with practice and drug management software. uh, uh, like uh, at this time, what how the practice of certain drug is going on. While some drugs, you see, even the FDA approved that, sometimes they recall that drug, sometimes the drugs are banned, so such kind of information is embedded over there. Is also HIPAA compliant, so the patients and doctors and the people involved, they really don't need to worry about the information leakage. Information leakage happens, but it is controlled or monitored through HIPAA. And then digital records improve data analysis of prescription habits. Batch refills can save time, and better use of generic or preferred drugs. Like it show in the system, if there is any generic drug other than the branded drugs are available, then it can allow to the doctors and the peoples involved over there, or even can give the options to the patient to choose from the branded one or choose from the generic one, because of the preference, also because of the price. Now, the ERX modules, as we discussed in a clinical decision support system. So ERX is basically linked up with clinical decision support system, and with that, it helps as the doctor, as soon the doctor try to prescribe that, it automatically send alerts or the pop-ups, and based on the patient history, as it is linked with patient record, EHR. So the system knows which drugs the patients are taking, age of the patient, gender of the patient. It can alert like drug allergies. If it can alert as drug interaction. You see the issue of the polypharmacy to people, those who are taking multiple drugs. So it's not always possible for the doctors and paramedics to keep record or remember by heart. So drug interactions modules automatically send alerts to the doctors about the drug interaction. Then alerts about the formulary alerts to tell the drug is either is recommended, not recommended, not reimbursed. So this kind of information you can get that. Alert can exist, ask about the pregnancy, kidney, liver function, safety, because it's linked with patient history and patient current status, health status. So based on that data and using the artificial intelligence, this system can predict that, and based on that, it can send multiple alerts to the doctor at the time of prescription and also to the patient at the time of taking the drugs. And dosing alerts can arise based on the age and size of the patient. So your dosage of a child is different from the dosage of an adult, and so keeping and monitoring them in an efficient way, we can do that with the help of EHR modules, ERX. Right? Now, let's look at the challenge. It looks all good, but is there any challenges involved with ERX? Why it's not widely adopted? Yes, there are. So what are the challenges? Paramedics, people working in hospital setup, they said like they get too many alerts, and it's sometimes uh, it's really disturbing for them as they feel that their workflow is being disturbed with that way. And so at this time, how we can minimize these alerts, and like we are facilitating the doctors, like but facilitating in a way which could be acceptable, and will not or will not alter completely their workflow. There are still issues at the pharmacist end, but these should improve over time. And still not clear how many adverse drug events are prevented with ERX, perhaps too soon to know. So these are some questions, right? So it's not clear how the ERX is helping in preventing the drug events, drug interactions, or any adverse event, because it's too soon. We at least need up to 10 to 20 years to reach to a decision. Uh, as the ERX are around up to like a 6 to 7 year, maybe more. Data, we have some data, but data is not that large that we can say something ultimately about the ERX benefits and the ERX demerits. We know that there are some challenges, and the people are working on them to solve that. Now, special components of electronic health record. Now, what are ER registries? Any idea? ER registries. You can just, if you can just read this word ER registry, it should give you some hint. Now, write whatever you have in your mind. So, in the EHR system, there are different kind of registries, or you can say a different kind of a separate record, a different kind of separate folder. Just like, they have the registries about the chronic disease. For example, issues about the registries about the diabetes, like how many diabetes, just to the issue, the main purpose is to keep record about a specific disease. Just like COVID, like how many cases of the COVID emerged in the last 6 months in a certain county, or how many patients are like diabetes in certain ethnicity. So this kind of information you can track with the EHR. These are basically an entry system, but the entry system about a specific disease. Just like you can rename a folder and can put all the information relating to a disease into that folder. Then research registries, high volume, allow research questions to be answered. So for example, frequently asked question, you can have a separate facts, you can have a separate registry for that. Then registry about the drug safety. I mean, as this is a link with the EHR system is linked with the EHR system of one hospital, second hospital, third hospital, and it's also linked with the FDA. So which drugs are currently banned, recalled, or halted? So this kind of information you can get over this release of the new drugs, availability of the new drugs, and usage of new drugs. This kind of information you can manage in safety registries. Then information about the immunization, like how many people got the vaccine in certain area, and immunization, cancer, biosurveillance. So this kind of information you can save in the public health registries. The purpose of all these registries, as I mentioned earlier, are to get some quality data, and then based on this data, you can take some better decision. So, and this data is registry later forwarded to the clinical management systems. Clinical management system is a special types of the clinical decision support system that help to further either to disseminate that information or to keep it for the future usage. Now, PMSS, Practice Management System. Before the EHR, when the EHR systems were not in place, the earlier version of the EHR systems used to call the practice management system. Still, if you can go in a remote area where are in the clinics where they are where they don't have the budget or they don't have much capacity to deploy the EHR system, they are using the practice management system. PMS are essentials to run any practice: billing, dealing with insurance, evaluating physician performance, and practice trend. Let me show you that how the practice management system work in a diagram. So you can say that the PMS is a smaller version of EHR systems with some limited or essential kind of capabilities. For example, what happens? You go to a hospital, okay? And so front desk, you go for the registration, and then the clerk go for the patient's scheduling. They check, they will ask you the information about your health insurance and other information, and check whether you are eligible for that, and even your condition, like indoor, outdoor patient, or you are is a serious, you are like having some injury, or you have some chronic illness. So based on that, first they decide that whether you are eligible or not. If you are, then the patient checks in, and then the clinical encounter start. You know, this is there are several sub-steps involved. Like when you see that when you just checks into doctor, you go for the vital signs, blood pressure, weight, height. Then the nurse asks you brief history, and they put everything over there. Then you wait there. Then they send you to the doctor office. Then the doctor sees you, and after that, doctor prescribes some medicine, and then you check out. Then all your charge are then entered through the different codes, just like ICD-10, ICD-11 codes. And after that, it sends to the claim or billing section, or to the person, those who deal with the claims and billing. And at the end, it generates EOB receipt, which is the explanation of benefit. And here they'll ask you to pay either the copay, or if you don't have any copay, then they will just send you a receipt. And the payment posting, and then it is reporting. So this was, you see that this is the simplest workflow, and this simplest workflow you can manage with the help of the PMSS, the initial version of the EHR system, you can see, right? Now, let's look at some challenges at the adoption level, and see that overall state of the art, what's going on at the adoption level. And for example, when you will graduate that, you will be hired as a healthcare information officer at some healthcare setup, and then you have been given a task to evaluate an EHR system and to deploy that. Then how you will do that? What are the process of steps involved? Right. Now first look for some numbers, some details that we have here, some surveys. So we have in the US, they have the HITECH Act. We will discuss about the HITECH Act later on in detail. But at this time, you can say the HITECH Act, the US has been behind many other developed countries until the HITECH Act that included reimbursement for the EHR. The HITECH Act, they have it was the act signed in 2009, and before that the US was very behind in deploying of the EHR, just like countries Japan, Germany, Norway, and but after that, with the high tech act, they gave a lot of federal level reimbursement. We will see that shortly, that how the federal is helping to the different healthcare setups in adoptions of the EHR system. One survey which was taken in 2015, according to that, perhaps as many as 96% of the hospitals have EHR, and most are participating in the meaningful use program. Now you see the growth from 2009 to 2015, significantly a growth in the adoptions of the EHR system. And then at the same time, in the same year, it says that the around roughly 86% of the EHR are much more have advanced than others, and large practice adopt at a higher rate due to large and strong finance. Now, here they also categorize that. We have the categories. I will show you in a minute what this means by the EHR adoption. So according to this survey, which they have take every 2.5 years, so they say like they have the level from 1 to 7. These are the quality adoption level. So at this time, you see that only 10.4% hospitals are at the level 7. Mostly we see level 3, we see 4, and so that's adoption is one thing. Second is the meaningful use, like how efficiently they are using. I mean, you can have a system with a Microsoft Excel, Word, or kind of the softwares, and if you are not making a proper better use of that, still you are using your the handwriting, everything, then you are not proper using that. So this stage from 0 to 7 stage is basically not only based on the deployment, it's also based on the meaningful use. So that's what they are saying, that we have a significant improvement, but they are really need to look at the meaningful use, or we really have to promote the meaningful use of the EHR system. The biggest challenge, if we see in the EHR system adoption, is the financial. It is okay for it is manageable for a larger setup, just like we have here Northwell Health, we have Long Island Jewish hospitals, and big setups. But for small clinics, it's not feasible even to go and buy and adopt. The managing of that softwares, it's not that easy. Physician resistance and loss of productivity. So this is interlinked. So physicians feel that it's basically it's a burden. They are the software things are consuming a lot of their time, and their productivity decreases. And ideally, it should increase that, because the reason is they as it's a new system, they have to get training for that, and it disturbs their workflow. They were like the old doctors, they are just used to phone calls, and they were not really tech savvy. Now they have to learn new softwares, having to enter the information over there. So it's not, they don't feel convenient and easy. So this is another challenge, that how to train to the people, how the people, those who are really the reluctant, and people those who have like the aged employees, how we can train them in a way, how we can facilitate them in a way, or to create a system that is very, very user friendly. Now, meaningful EHR and meaningful use challenge. Meaningful use, that EHR is deployed, but that how we can efficiently use this EHR system. First thing is the workflow challenge, as it disturb or significantly disturb the workflow. Now, everyone must adapt to doing business differently, but some seek strange workaround. So how we can deploy the system, and how we can modify our existing workflow so it would not hurt much the previous one. Reduce physician-patient interactions without careful forethought and planning. There will be a less eye contact interaction with the patient. You see, this is a bigger issue at this time. It takes around 1 hour when you go for a doctor clinic, but I mean, how many times a patient and a doctor interact there? Maybe 5 to 10 minutes. The rest time we'll spend in with the nurse and giving some history and other thing. Can we increase this time? Definitely, we can increase this time if we can just improve, optimize our workflow. Usability issues. Some EHR are not user-friendly and require too many mouse clicks, illogical steps, and that impairs overall the workflow. So we have to look, this is the main of the usability thing. We have to ask through a survey to a different people, those who are using that, are you like that? What are the issues you want to improve? Maybe issue with the colors, maybe issue with the too many pop-ups. We have to discuss with them and sort these issues, list down these issues, and then post these issues to software stream to work on. Then we have integrations with other systems. Practice may need to be to build expensive interface to communicate with the HIO, Health Information Office's practice management system. We have to look at that, whether we can use our system standalone or what are our requirements. Do we need to really share the information from one hospital to other hospital, which it should be the requirement. I mean, deploying an EHR system that reside within one hospital does not make sense. It does not fulfill the meaningful use. If you are not getting the information like the outbreak information from other hospitals, from the other regions, then you just converted your manual system into a digital system, but you really did not increase, did not making it is a best use of that system. You could only get best use of the system when it would be interconnected. Lack of interoperability, the challenge, we discussed like some EHR are not capable of communicating with each other without additional technology, thus impeding data sharing. As I said, there are 75 different vendors are available. Maybe the vendor, the hospitals through which you would like to link your system, they are using a very old technology, or maybe they are using very high-end technology, and your system is not able to directly link with that. This is an issue. This is an interoperability issue as well. Maybe both you are using the nationally recognized standards, ontologies, but because of that, you are stuck. Privacy concern, and privacy concern are linked with legal concern. What happens if you link your EHR system with the national or regional hub? And what happens? Who are responsible if anything data breach happens? And what would be the legal consequences of that? So these are still a question which are really need to address, and people are working on that somehow to sort out the issues, somehow to streamline the things. If any breach happens, then how we can handle this. We actually teach this thing in HCI 10002 course and HCI 1015 course, which is about the standards, ontologies, HIPAA. So all these things we teach in detail in HCI 1002 and HCI 1015, and we are offering this course in spring semester. Now, inadequate proof of the benefit. And another question which the people, those who haven't deployed with the EHR system, they ask like, we don't see any benefit of the EHR system. You have to train the staff, you spend a lot of money, but where are the real advantage? Where are the real benefit of that? This question is probably, as I said, it's probably too early. We cannot really comment on that and can based on the chart data set. It really takes a lot of time, and at this time we don't have much proof to say that. That's what like the federal at this time they can just promote. They really cannot enforce that. because like the data is not enough to force the people to use the EHR. Now the high-tech act, which I just mentioned earlier. So the act, with that act, US Federal and the Institute of Medicine, they have the opinion, they think that using the EHR reduces the overall medical errors. And that's what in 2009 they have started a program with the Medicare and Medicaid. And they said, if there is a practice, if there is a hospital, clinic, or bigger setups, and they have eligible practitioners, we'll see that what are the eligible practitioners mean, and if they have already registered for reimbursement, and then they also have the EHR software coming from registered vendors, then they can claim for the reimbursement, right? And they have already gave this reimbursement to these numbers. Now look at these steps. So what this mean by eligible practitioner? Who are the eligible practitioner? So you see that we have two systems, Medicare and Medicaid. So both have a different definition. So Medicare, you know, we have Medicare says like the EPs are only doctors, like people with mainly MDs, ND or DOs degrees. Whereas according to the Medicare, they even consider midwives, dentists, physician assistants as an EP. So what this mean? If a midwife or a physician assistant has a separate clinic and would like to deploy the EHR, he could get the reimbursement from the federal through this program, through under the Medicaid, but not under the Medicaid. Now, the goal of this meaningful use is, meaningful use mean, they say if you use the electronic health record system in an efficient way, it improves the quality, safety, and efficiency, as it reduces the disparity and the health medical errors. Second, these information are based on initial data. Secondly, they say it engages patient better, and between doctors and patient, between doctors and their hospitals, and between patient and patient. Thirdly, it improves the coordination and ensure adequate privacy and security, as they are compliant with the HIPAA. And the last point is it improves the population and public health, like through alerts, through the registries. However, EHR must be certified by several organizations as capable of meeting meaningful use objective. So now, if an EHR, if an EP, eligible practitioner, register for reimbursement and buy an EHR software from a registered vendor, apply for reimbursement, and then deploy and make it meaningful use of that, he, she, or the organization can claim for the reimbursement. Now, this is an example of a small EHR, like maybe it has some EHR come with a 3-month trial, some come with a web interface, some come with like a window-based interface. But this is an example of smaller EHR. We have a mid-level EHRs. Mid-level EHR are one step better, come with more features than that. Still, they don't have the feature just like clinical decision support system. But the really bigger system which they have, like in Casier Permanente and the other in the healthcare setups, they have a system with a huge setup. Like it has all the modules from ERX to the clinical decision support system, and also have the training modules. Everything is embedded into their system. So these are examples of the large example of, just like we have, I guess most of the people are familiar with the Epic, as you mostly working in the healthcare setup. So that we call the larger EHR. Now, implementation steps. What we have to do if you have to implement an EHR. Now, take the example that, like, as a health information officer in your organization, you have been given a task to look at the vendors around, and the task is to see whether our organization really need an EHR, and if our organization need that, then go and deploy, buy, deploy, and train the staff. So you will start with really develop stuff. In the develop, you have to ask a couple of questions to yourself, to your colleagues, to your organization. Why are you considering EHR? Are you really need that? Are the staff is on board? How many people will be willing if we go with the EHR? That's what I'm saying. Plan, and do your own research. Go on internet and check that, read the books, go to the survey, maybe ask to the other hospitals around if they have deployed that, what benefits are they are seeing, what issues they are facing. Then, maybe to check for the methods that if the available vendors are there, what are their what they are providing, cost, feature, trainings, and analyze that. At the end, when you have all the information, analyze, re-engineer workflow, consider all process, likely change when you transition from paper to electronic, how you will link that, how you will train to the older staff, and how long it will take that. Are you deploying the software entirely at once on certain date, or it will be a very gradual kind of transition. And at the same time, you have to look the other softwares as well. For example, if you are just managing the appointments, can you just buy a smaller software, and instead of deploying the complete, if you can manage just booking, you can manage that in other softwares as well, the smaller softwares. And you can look for, do you really need the web system or the desktop system? Because web system will cost more, because it would allow the people to access from anywhere sitting at home, but for the desktop system, you have to maybe employ the people permanently, those who will come over there on site and do that. Then what you have to do, you have to purchase in a combination, or you have to build interface, or you can just buy a 1 module, 2 module, or 3 module. For that, you really need a look for your hardware and softwares as well, like how capacity of the people, capacity of your network, speed, so that everything would come in should come in a document, and based on that you should take a decision. And now consider that you reach a decision that really you have to go for an EHR. So the steps involve develop, select, and again develop. So what this mean, like development, first step, you have to list the vendors, those who are selling the EHR, and look for and send for request for a proposal. Ask them to pitch you their system. Ask them to tell you like what system, what features are available, and how it's differentiate, or how they differentiate their system from others available system. Then after that, when you will select the vendor, then select carefully and make a plan where you will gradually shift from your manual system to electronic system, and maybe keep up for some time. At the same time, you also have to keep in mind EHR system is not just deploying the software. It's all about training. You see, if Costco at this time, maybe you have experienced or not, if you go there, they still have a old black and white kind of the system. That's if they like to change a new graphical system, they have over 100,000 employees to train. Same as with the hospitals, the training cost, and you have to really discuss with your vendor that what happens. We hire 24, 10, 15 people every year who will train them, and And also at the same time, if you choose a cheaper software, maybe after 5 years, 10 years, the company get bankrupt. Then what you will do that? How you will, if you need new thing, what you will do that? I mean, so based on that, you really have to check that. And also, how it would go live. It would be you will deploy at once, or it would be a gradual change. And if there would be any kind of problem occurs, who will handle that? The employee, you will hire the employee on your end, or you will have to call to the team? If it is a call to the team, then how long it will take? So it's all matter of sorting and really make a document where you can have to point when you need that. Really create a comprehensive document, and everyone in your organization, or maximum people on your organization, should be on board. Otherwise, EHR would not work. Just don't go for the sake of reimbursement and money. Otherwise, it would indirectly create a lot of issues and confusion for your organization. So in summary, we say the overall EHR felt to be critical for the US healthcare system, and we see the issues with the paper-based system. They are less legible. Paper-based healthcare are severely limited as because of the federal grant and the reimbursement program. It really pushed the adoption of the EHR, but still, they have a lot of challenges with the technical challenges, with the training and logistics challenges. In spite of the potential benefit of EHR, we say many challenges, association and adoption. And also we say the planning, training, and strategizing about the EHR is important than the actual EHR brand purchase. So we really have to focus on the thing we really need. Do we really need that? If we need that, then we really have to clearly write down somewhere, and really have to do a good research, thorough research, before going towards purchasing and deployment of the EHR. So that's all from this lecture. I'll see you in the next class.